Good evening, colleagues. It's my great pleasure to again welcome you on this Lloret case conference. My name is Pieter Evenepoel. I'm a nephrologist working in Leuven, Belgium, and I'm also the chair of the Lloret initiative. For those who don't know yet, Lloret has been founded something like 10 years ago in 2016 under the umbrella of the ERA CKD MBD working group. And the aims are fourfold. In a way, we want, as a group, revitalize bone biopsy as a clinically useful tool in daily practice. Also, we would like to promote and organize a pan-European research in the field of renal osteodystrophy. We also want to closely collaborate with other bone and mineral societies. And finally, last but not least, we aim to improve and distribute the knowledge in the field of renal osteodystrophy. And to that purpose, we're organizing a yearly winter meeting, which is held in Leuven. I will discuss later at the end of this seminar. Also, we're organizing webinars, and finally, we also write consensus meetings on topics which are hot in the field of CKD-MBD, and more specifically in renal osteodystrophy. For example, we published some years ago a consensus statement on the diagnosis and treatment of osteoporosis in patients with advanced CKD. We felt there was a need to give some guidance in the absence of good guidelines on this topic. And also more recently, we produced a guideline regarding the recommended calcium intake in adults and children with chronic kidney disease. I do recommend you to go to these papers. We aimed for having something which is easy to digest and really helpful in daily clinical practice. So second, also within the Lloret initiative, we aimed for learning by practice. In a way, the best way why you can at least translate knowledge into practice is having case discussions. And to that end, we set up some years ago these webinars where we present usual cases and also sometimes a bit special cases, but in a way to learn by practice. And again, it's my pleasure today to introduce the next one, which is dealing with a case I do believe you all will see at a certain time point in your practice. It's a 70-year-old man with chronic kidney disease, grade 4, osteoporosis, and low bone turnover. And many cases you would say, oh, this is really difficult. Let's just keep it silent and do nothing. And that's what happened in the past in many cases. But we do believe that also these patients maybe benefit from specific therapy. So this case will be discussed by Professor Hansen from Copenhagen University. And this case then will be discussed by and also by Professor Thomas Andersen. He's a bone biologist and he's working at the Odense University Hospital. And then later on, during the case presentation, again, we would like to have an open discussion. So please use the chat box to present your questions. We would like to address them. We would like to involve you to ask your questions. But in between, also the panelists will hopefully fuel the discussion. And today we welcome Renate de Jongh from Amsterdam University in the Netherlands and Maria Jesus Lloret from Pieter University in Barcelona. So without any further ado, I would like ask Professor Hansen to present her case and to open the discussion. Thank you.
Thank you very much, Peter. I would like to present this case, which may be a bit challenging, but also reflects some of the considerations that we have gone through the last years when we have started treating patients with CKD and osteoporosis. And this is the case of a 70-year-old man with CKD grade 4 and osteoporosis and low bone turnover. And this is my disclosures, and I'm presenting together with Thomas Levin Andersen, and this is Thomas Levin Andersen's disclosures. So begin with this case. It's a 70-year-old male, which we see in the outpatient clinic. He has chronic kidney disease, grade 4, with some moderate albuminuria. The cause of the underlying kidney disease is unknown. He was referred with like small kidneys. Biopsies was not possible at that time point. But we know that he have had hypertension for several years, and he also have some atrial fibrillation. He have had no form of fractures, and there is no history of osteoporosis in his family. At this time point, his medication is furosemide and potassium, as well as amlodipine, which all are provided due to the hypertension. And he also have warfarin for the atrial fibrillation. He's not on any kind of RAS inhibitors or SGLT2 inhibitors due to he have not been able to tolerate these treatments. In addition, he is having alpha-calcidol due to an increasing PTH and cholecalciferol 35 micrograms per day to achieve a relevant level of 25 hydroxyvitamin D. He also has some calcium carbonate, 400 milligrams 2 times a day to supplement his calcium intake. And then he, at the moment, are having OxyContin and gabapentin due to back pain. So here the present clinical problem begins. He have had.
If I may interrupt you, so
Yeah,
my
sure.
first question would be, I mean, the calcium carbonate is 400 milligrams 2 times a day.
Yeah.
Is this the elemental calcium content you mean?
No, it's actually just the dose of the calcium
so it's
supplement.
about it's 800 milligrams calcium carbonate, which
Yes.
corresponds then to about
200, 300 milligrams
of
elemental calcium. Yeah.
Okay.
So he have some calcium intake on his own. You know, in Denmark we like milk products a lot, and so he's actually having some on his own, but we still use it, and also a bit as phosphate binders, of course. But even though he have not had low or severely high phosphate at any time point. Mm-hmm. Yeah, so he has severe back pain, and he have initially an MR or an X-ray performed, which is supplement, and there is added an MRI of the back, and as you can see, he has some fractures. This is the 11th tracheospine, and also TH7, and there is also one more fracture in the spine, which provide or gives him severe pain. And this is more than 25% reduction, which is of important to have to be approved for different kind of treatments in Denmark. He have had no previous trauma. They occurred spontaneously, or at least the back pain came spontaneously. And he have had no other fractures, but he has reduced his height 17 centimeters since he was young. We performed a DEXA scan to describe the BMD, and in the vertebral spine, the lowest T-score was not that low. It was minus 0.2 at the level of L2 to L3. And at the hip, the T-score was minus 3.3 and minus 3.0 on the right and the left hip. So actually quite severe reduced BMD in the hip.
Yeah, and I would like to start the discussion at this point. So we have a patient 70 years old with several vertebral fractures, and then the DEXA is performed and we see these results. So I would like to ask the panelists how they interpret this kind of discordant findings between the lumbar spine and the femoral neck. How would you, reconcile this kind of apparent discrepancy.
Yeah,
So Renate, if you would start.
Yes, thank you, Pieter. That would be really nice. Yes, it's really this discrepancy because the vertebral factors, of course, you would expect the T-score to be much lower in the lumbar spine. And it's I always, when I see this, I really would like to see the pictures of the DEXA scan because of course there are a tremendous amount of reasons why there are false positive higher values reported than is the true BMD of the lumbar spine, such as atherosclerosis with calcifications that project in front of the lumbar spine in the aorta, or that there may be some over projection of other material that's in there. He didn't have any surgery in the past. I didn't see anything.
No.
But of course, there may be some that the markings on the DEXA scan are not completely correct because it may be really difficult, and it's normally automatically done by the DEXA machine. And if it's not, well, if the radiologist or the one who performs the DEXA is not keen on looking at those markers, it may give you false higher values than the true value.
Mm-hmm.
I'm completely agree with Renate. This is a dissociation about bone mineral density between the different sites. Maybe in the MRI, we can observe some degenerative processes that could also impact in the sobreestimation of the bone mineral density. And the other thing that I would ask you is, do you have some data about, for example, ultradistal radio determining the trabecular, or how the trabecular is affected in this case?
Yeah, or the trabecular bone score, perhaps. Do you have it available in your hospital?
TBS,
Yeah, unfortunately, it's not routinely performed, so I have not these measurements available in this case.
Yeah.
Mm-hmm.
But in most cases, you would expect that fractures is the most important, let's say, cause of falsely high T-score in the spine. And here you have a case where this has been excluded by MRI. So it's strange that you find this kind of, I mean, dissociation of discordance between the lumbar spine and the femoral neck. And I do a little bit challenge the comment by Renate that aortic calcification is an important cause or an important confounder. At least we did check it some years ago, and we did find a very tiny impact of vascular calcification, but it's clinically not relevant. So it's something that we should not over exaggerate as being an important confounder, and certainly not a reason why you should just forget about results of lumbar spine, the AP results in a patient who is calcified. The impact is clinically most probably not relevant. So, but this is something we often see, that this kind of discordance between different sites, and it's always a challenge.
I think, Pieter, I agree. I know that's only of a minimal impact. And actually, in practice, what I experience is that in these cases, I look together with the radiologist at the pictures, and that 1 in 10 of these discordant scans, there is some discrepancy in the markings or the calculations of the measurements. So that's actually, I think, most important message to give. If you don't trust this, just look at the pictures with the radiologist or the one who reports on the DEXA scans.
I think that's an important take-home message. I just want to say that the next winter meeting, we have a whole session dedicated to how to interpret DEXA scans, and certainly I do believe that also will be discussed, that we as clinicians sometimes have to go back at the images and not only rely on the values given by the people of the DEXA unit.
Yeah, and finally, it's important to know the bone mineral density in lumbar spine. I think maybe because it will be easier to monitor a long time, but this patient, to know the bone mineral density at lumbar spine will not change our therapeutic attitude probably, because he has a very high risk of fracture. He had 3 vertebral fracture, is very, very high risk fracture independently of their bone mineral density.
Yeah, correct. Okay,
May I
Pieter.
ask another question, Ditte,
Yes.
about the history of the patient?
Of course.
Because he now presents with the severe back pain, but were there periods in the past which he experienced severe back pain?
He cannot remember that he had experienced any back pain until at this time point. But he had been, the height has been reduced for some time, so that's not completely new that that his height is reduced, but the back pain has just emerged here during the last weeks before.
Because looking at the MRI, they don't look like all fresh fractures, so I think there may be old and new ones. Not the right setting, but I think there may be a combination of old fractures and new fractures. Yeah.
And I also just wonder, this is a 70-year-old patient, so is it sufficient to exclude, for example, morbus scalar? I mean, there's no, I mean, he's 70 years, so is it sufficient to exclude this MRI? Malignant melanoma, myeloma, I would say. A myeloma, can you exclude a myeloma in this patient?
Well, I don't think so. I would exclude it on laboratory tests in such a patient. Yes.
Yeah. He also had like immunoglobulins and the EM component, and so the light chains measured, they were normal.
Okay.
Or according to the reduced kidney function, but yeah, there was no signs of myeloma in the lab.
And other in the biopsy as well.
Okay. Yeah.
And another question about their clinical medical antecedents, because it's a very, very high osteoporosis patient, and did he took corticosteroids before or no?
No corticosteroids before, no.
And I'm also curious about the past and, for example, his weight and his nutritional status. Were there any problems with that? Low weight, bad nutritional status?
Normal weight at this time point, but actually during the next 2 years, he's losing weight and also reducing his physical activity. But that will be part of the story to come. But he is due to this pain also like less physical active and also reduced physical activity. Yeah, losing some weight, at least due to the muscle waste.
And Pieter, you should interfere if we're taking too much time.
No, you can go on. I mean, we have 1 hour, but I mean,
okay.
So yeah. I mean, in between, I can just ask a question from the chat box. I mean, Rosa Scuteri is asking whether in this case you would also test for hypogonadism. Of course, he is 70 years old. I mean, did you check the gonadal status in this patient, Ditte? And if not, why not? Or
Yeah, actually, I usually measure it once in these patients, and I must admit, if there's something where it's low, I refer them to the endocrinologist, and they looks further into if it requires any further evaluation or treatment. So I do not myself treat for hypogonadism, but that's a part of our workup to measure the gender hormones.
Yeah, and do you have them in this case? Excuse me?
Yeah, and they were normal. Yeah.
Okay. Yeah.
Yeah, just like a thyroid function. The thyroid function was normal.
It's also part of the routine workup, and it was also normal.
And actually, what I also wanted to ask is whether there were any remarkable things in the time that he developed his peak bone mass. I always like to go back because the bone you develop in your youth until you're 30 years old is the bone you need to use during the rest of your life. So was there anything remarkable in his youth? Was he a heavy smoker, drinker, immobilized, whatever?
It's a good question. Not that I'm aware of, but I haven't asked him directly, actually. So I will ask him next time.
And their antecedents of familiar hip fracture in first degree?
No familiar history of like especially early appearing osteoporosis or fractures. No.
So meanwhile, we have addressed almost all risk factors, and apparently this seems to be reassuring. So I think Ditte, you can go on with the case and go to the biochemistry.
Yeah, sure. So here you see the biochemistry, and the figure shows the ionized calcium in blue, and the phosphate in yellow, and the PTH in gray. And as you can see, the ionized calcium lies very normally around 1.2, 1.3, the blue line. The phosphate is also within the usual target, around perhaps a bit higher, 1.4 to 1.15, something like that. And then the PTH increases from 2016 to 2022. It increases. You see the PTH on your right, the PTH scale, and it goes from around 8 or around normal. You have the reference range for PTH here at the bottom. It goes from normal and increases up to around 25 picomolar per liter. So around 3 times the upper normal limit at this time point, which he have this clinical problem. The alpha-calcidol was initiated at this time point around 2018 when the PTH started to rise. So this was his like MBD biochemistry.
So Ditte, I mean, nowadays we pay attention also to the cholecalciferol and the nutritional vitamin D and the 25 hydroxyvitamin D.
Yeah.
Do you check it? Because I mean, apparently you're giving alpha-calcidiol in your patient whenever the PTH starts rising, without first checking the 25D levels?
No, actually we measure the 25 hydroxyvitamin D regularly. Usually, 2 to 4 times a year, so perhaps even 2 regular, and if it's below 75 nanomolar per liter, we make supplementation.
Yeah.
So he has been supplemented. I can go to the next slide. This is his 25 hydroxyvitamin D, which is 86 nanomolar per liter, and he is supplemented with cholecalciferol as shown in the first slide of 35 microgram a day.
Okay, so now you show the data on the bone turnover markers. Is this something you do in all your patients that's presenting with, let's say, flagellative fractures?
Yeah, not in all my patients without any bone problem, but in the patients when they present with fractures or with osteoporosis on the DEXA scan. So if they like have these criteria for osteoporosis with low T-score or fragility fractures, I do the bone turnover markers as demonstrated in this slide. And
so the attendees can read results of this analysis, and I would again hand over to Susa and Renate to comment. I mean, how do they interpret this bone turnover marker data?
I just had another question actually. Was the CTX, was it in the fasting state?
No, it wasn't. And actually, usually CTX is a bit problematic because it's cleared by the kidneys. So usually we do not measure it routinely, but it was measured for him, but it's not fasting.
And
No.
I would like to ask you, Ditte, why CTX and not TRAP5B?
TRAP5B has just recently become available in our lab for routine measurements. I think for many labs it's still for research, but we have it actually for routine measurements now, but it was not available 2 years ago. So so these were the ones which were available in 2022.
But
Okay.
also this means Ditte, that you would now at this stage you would prefer TRAP5B above CTX?
Yeah, because TRAP5B is one you can use in patients with reduced kidney function. So the ones we usually would like to measure in patients with kidney disease is the bone-specific alkaline phosphatase, the intact P1NP, and then the TRAP5B. And the TRAP5B is like for resorption marker, and the bone-specific alkaline phosphatase and intact P1P as a formation marker.
I might challenge a little bit this idea because TRAP5B is not actually the resorption process you look at. It's more maybe the abundance of osteoclast. So I feel it's TRAP5B and CTX is maybe it's not measuring one-to-one the same. So one has to just be aware of that.
Thank you, Thomas.
And it's quite luxurious, Ditte, that you have all these bone markers available in your hospital. And I think that most of the clinicians don't have all these options. What would you advise to clinicians? Which marker you think is most easy to use and interpret?
Yeah, if you're not, if you do not have all these bone turnover markers available, you may use the total alkaline phosphatase as a routine biochemical marker also for bone turnover.
For us, sorry, for us, we have not available the use for all patients of these biomarkers. But I think it's important if you have these biomarkers, you can choose the more properly therapy. It's important to differentiate it about the turnover, and you can and this can guide if you have no possibilities to do bone biopsies. This can help you in some cases. We do in some specific cases to guide our treatment. Yeah.
So besides the 25D and the bone turnover markers, and as we discussed, I mean, if you don't have them, rely on the total alkaline phosphatase in the absence of other liver dysfunction tests. Besides these tests, is there something else you would recommend to be measured? And I'm just echoing the question by Sandro Mazzoferro, who's asking, is the acid-base balance, is this something you would certainly also include in your analysis? I mean, do you have data on bicarbonate, and do you feel this is something that we need to assess?
Yeah, the bone may be considered like a buffer for the acidosis in patients with kidney disease, and it may be so that acidosis decalcify the bone. So but yeah, there was no acidosis at this time point. It was the bicarbonate was 22 millimolar per liter.
And should we also measure magnesium in these patients? What do you think?
It is a part of our routine lab measurements. Usually it's normal because due to the reduced excretion in patients with reduced kidney function. But of course, you may have people with some gastrointestinal problems, having low magnesium, low calcium, where this may be the cause of osteoporosis and fractures. So I think it should be measured at some time point during the workout or workup.
So in a way, this patient was seen as a CKD grade 4 patient with well-controlled PTH, 3 times the upper normal limit, with bone turnover markers, which at least point into direction of more like a low normal bone turnover. Correct?
Yeah, that would be my interpretation. So, and I think this would be the time point where some people will like evaluate and decide if we should treat or not this patient in any way to protect the bone and against any further fractures.
So the question is to the panel again. I mean, you have this clinical vignette of this patient who is showing up in your outpatient clinic, and he's asking what to do next. So do you have sufficient information, or would you say, okay, this is fine, this is a clear-cut case of osteoporosis with several vertebral fractures, go on and treat? How would you deal with this case?
For me, go on and treat, because we are agreed that a very high risk fracture. The question is with what we should treat. That's another point, but I think we have to do something because more than 2 vertebral fractures and a DEXA scan mirror to 3 is very high, and the imminent risk fracture is very high because he has a fracture, acute fracture, and the risk in the next months or years is very high, and we cannot postpone or delay the treatment.
So you would start with therapy, and then what kind of therapy, Susa?
If I can, obviously, yeah. I did a bone biopsy. That's the best to discriminate the bone turnover, but only for the high. If I don't know which exactly the highest morphometry, because I have not available the bone biopsy, and we have a very high fracture. In general population, the advice will be a potent anti-fracture treatment, that's sure, and not an oral. A parenteral anti-fracture treatment will be the best option, I think. And we have to choose between an anabolic treatment or anti-resorptive. And
may I ask, Susa, why do you say it should be parental and why not oral? I mean, when you look at anti-resorptive treatment, bisphosphonates.
Yeah. I think because the severity of osteoporosis, the parental, I refer subcutaneous. You can use bisphosphonates, and even intravenous bisphosphonates may be an option, but in this case, with this CKD state, for me, will not be the first option. And with these results on bone biomarkers, not at all. But I think that the concept is that he needs a potent treatment, and we will see what, but a treatment, yes, and potent treatment, not an oral biphosphonate.
To summarize, you would proceed with therapy, preferentially some anabolic because of the low bone turnover, but you would be pleased if a bone biopsy could be performed to confirm the low bone turnover status. Correct?
Yeah.
So Renate, do you agree? Would this be your plan, or would you just go on and start therapy without a bone biopsy?
We now rely on the bone turnover markers that we have here. That's the only information actually telling us something about the bone turnover. And I think it's also good to take into account the time frame between the last fracture and the measurement of the bone markers, because we know that the bone turnover is increased after a fracture. Up until, well, we discussed this earlier, until 6 months or a year even. So yeah,
it's a very important point. So the time frame
may
since the
even be
last
worse
lecture.
that we see.
But still, the bone turnover markers are relatively low. So even despite the recent fractures, so which normally would push them into the high levels, but even with knowledge of a recent fracture, this makes it more remarkable. These are really like in the lower end, these bone turnover markers. And you will show, Ditte, go ahead, please. Yeah.
Yeah, it's just this work by Hannes Jongh and also you, Pieter, which has explored the use of bone turnover markers for diagnosis of high or low bone turnover. And in the lower part, you have like low turnover cut off for low turnover, which were like around 24 for the bone-specific alkaline phosphatase and 49 for the intact P1NP. And I think this is just around this the same level that these bone turnover markers are found, and they're not like completely in one direction for high or low bone turnover. So that's for me, as it is possible in my unit to perform bone biopsies, we continued with the biopsy. And also because when I discussed treatment with the patient, he was like a bit unsecure, that he wanted to make sure that we provided him the correct treatment. Of course, patients always wants to, but he even were interested in going further and perform a bone biopsy.
Yeah, and also we mark in this table the high negative predictive value of these biomarkers, but a very low positive predictive value. So meaning these biomarkers help to exclude a certain condition, but not confirm it. So these bone biomarkers you have shown, I mean, could also, I mean, really also seen in a patient with a normal bone turnover on bone biopsy. So in order to confirm the low bone turnover, a bone biopsy is the only option.
Yeah.
Okay.
Should we continue, Pieter?
Yeah, certain. Yeah.
Yeah. Great.
So then the bone biopsy was performed, and Thomas, you will explain us.
Yeah. So in the end, we did perform a bone biopsy on this patient to see what's going on inside the bone. So this is a transiliac biopsy. It was embedded in plastic. You will see that the later biopsy will be a little bit different. So this was embedded in plastic, and you can see both the cortices at each end, and you can see the trabecular bone in the middle. And we did both Jongh staining to look at overall structure and what's going on from more static perspective. And the lower one is to look, which is the green and black, is we were looking at inlabeling with tetracycline. Tetracycline allows us to look at how the mineralization is going on at the moment inside the biopsy. So when we did this analysis and tried to analyze how big a fraction of how much bone is there, so you can see what we call trabecular bone volume was actually not lowered as you would expect of an osteoporotic patient, but actually a good mid-range, actually reasonably high. If you looked at other aspects of the bone biopsy, we were looking at different parameters. You can first look at the extent of osteoclast surfaces. It was only 0.1% of the surfaces was covered by an osteoclast, means that it was very few. So from an osteoclast perspective, it was a relatively inactive from a remodeling point of view. But when we looked at it from a mineralization point of view and osteoid surface, you can see it was a bit higher. You had a 10% osteoid surface per bone surface, and the mineralization surface was around 4%. So it was not a dynamic, but it was in a lower range of the bone turnover. Furthermore, we did also analyze what is called the mineral appreciation rate. And this is a measurement of how the measurement is, I can see the unit is not right, it's not percent, it's actually micrometers per day. So here it's, we measured the distance between the two labels. So they were giving a label 11 days in between with tetracycline, and we measured then inside the biopsy the distance between these two. And we could see it was 0.5, so it was also in the low range. This means that the osteoblasts, while they are forming, they are not as efficient in mineralizing as they should. And when we also looked at what we call osteoid thickness or width, you can see it also is lower. So when we look at the TMV criteria, the turnover is in the low range, and especially when you look at it from the osteoclast perspective, it's definitely in the low range. Mineralization was normal. And if you look at what we call the volume, it was in the high end when you look at the trabecular bone volume. But if we look in the cortical bone, you can see the cortical bone is extremely thin, very porous. So it means that there's actually a very big effect on the cortical bone instead. So that was the view at the time point when we started treatment.
Okay. Thank you for this very nice, let's say, discussion of the bone biopsy. So Ditte, how did this help you, and how did you proceed?
Yeah, how did we proceed? We have these multidisciplinary team conferences where endocrinologists, nephrologists, Thomas Levin, Andersen, pathologists participate, and we discuss such cases as this one. And we found this patient where we have both bone turnover markers and the bone biopsy pointing towards low bone turnover, and he had osteoporosis, which also gave the indication for treatment, and therefore we decided that we would suggest him to be treated with teriparatide for 2 years in the dose of 20 micrograms per day.
Okay, so since time is running short, I would like to ask the panelists very briefly to answer whether they would go for the same treatment in the absence of a bone biopsy. So in many centers, bone biopsies are not available. So in the absence of a bone biopsy, would you also then in this patient have recommended this treatment? Renate and Susan?
Yeah, probably yes. Yes, for me, because sorry.
That's a short answer. Renate,
No,
for
no,
you
no,
the same? No?
I don't think so, actually. No. I will be a bit reluctant because of the positive predictive value of the bone turnover markers, and yeah. And I also, that's just one thing, when we start with the teriparatide, I always need to think about what are we going to do after stopping the teriparatide after 2 years. So that's also something that's always in the back of my mind, even when prescribing teriparatide. Yeah.
So what would you have would you have done then?
I mean, now it's easy because we have the bone biopsy, so that's not so it's very difficult because there are no other options. But I don't know. I'm aware that we should do something. So I would refer the patient to a center where bone biopsy can be done. Probably that's how we arrange it here in the Netherlands. I mean, they visit me one day and I do the bone biopsy, and it's the peripheral doctor that takes care of the patients. But would we dare to give bisphosphonates to such a patient, or denosumab or whatever? But with denosumab, I also have the same question: what are we going to do next after stopping?
So would be an anti-resorptive agent would be like a big mistake in this patient?
I don't think so. I mean, we don't know in this adynamic bone whether it's gonna. If you look at the postmenopausal women with low bone turnover markers, the bisphosphonates and denosumab anti-resorptives, they do work. We know that.
Yeah. Probably it changed a lot in your position if you are an hospital with bone biopsy viability or not. Your attitude will change, because I agree with Renate that we don't know probably what's the correct way. But if we have to take a decision with this information, we have a bone biomarker that it seems that it will exclude a high bone turnover. We have a very high risk patients, and we have to do something relatively quickly and relatively with potent effect. And I think it's important to know, be obviously prudent. We have to be cautious, but not nihilist. We have to do something. And FSM is important, not wait to bone biopsy to do something with the treatment. That I think is an important message.
Well, and
yeah, and I would add, like, I mean, there's chat box also, people ask why, and this is a question from Jordi Bover, why not consider romosozumab in this patient?
yeah.
Would this be something like a bridge too far?
For me, it's quite far in general for CKD patients, and it's true that another question that I would ask Ditte is if this patient has another vascular event, cardiovascular event or not, because for example, the vascular calcification in the X-ray, because probably the answer to start romosozumab will be, in my opinion, no, because it's a hypertension, chronic kidney disease, advanced chronic disease with proteinuria, not controlled proteinuria because it's an A2, I think, or A3, and the vascular risk is high. But if indeed he has vascular calcification, I some concerns about this treatment.
Okay, so do you know about the vascular history of this patient, and did you consider this patient for romosozumab or not?
Oh, there has been some warning signals on romosozumab for increased risk of cardiovascular events, and even in the patients without chronic kidney disease, I know that our endocrinologists are reluctant to use it if they are not like cardiovascular healthy or having good control of the lipids and so on. And in these patients with CKD and high risk of cardiovascular disease, I never consider romosozumab at the moment, actually. But this patient had only had atrial fibrillation and hypertension, but no cardiovascular events as such.
Okay, so this patient was treated for 2 years with this teriparatide. So
yeah,
what was the outcome? Did it help?
So we'll continue, and this was just to demonstrate for the audience that there have been a lot of like suggestions how to use these bone turnover markers, and if you are in doubt, then do the bone biopsy. So it's a bit like this we followed, like low bone turnover, then consider anabolic treatment, a high bone turnover, the anti-resorptive agent, and of course this patient was in this low bone turnover group. And perhaps I could skip a bit. There is this, but it was mostly on that there has been like almost no randomized trial looking into teriparatide in patients with CKD. So, but at follow-up 22 months now, his eGFR has decreased to 15 millimolar per liter per square meter, and he has experienced no further fractures, but actually still have pain in the back. He has developed acidosis, and he is provided with sodium bicarbonate at the moment. Some of the concerns which have been reported for teriparatide treatment in the observational studies that exist is an increased risk of gout or hypercalcemia, and hypotension have also been reported. So we looked especially for these things at follow-up, and he have had no such problem during these 22 months. And this is his MBD biochemistry, and it's the same figure as before, just extended for 2 more years. And actually, as you can see, the PTH went down after we initiated the treatment, and also the bone-specific alkaline phosphatase decreased. And this is a bit, especially the decrease in bone-specific alkaline phosphatase was a bit surprising to me.
So you have this patient been treated with this PTH analog for 3 years. You don't see the biochemical response you would expect in a way, but he's doing well. So everyone happy, but after 2 years, you have to do something else, as we just discussed. I mean, you need to do something else after giving an anabolic agent, because normally you can only give it for 2 years. So you were, I mean, this is the patient. So what to do next? Did you move then to another therapy, or I mean, what's the follow-up with this patient?
Yeah. Already from the start, actually, I planned that after 2 years, it's like Renate suggested what to do after 2 years. And we plan to do a bone biopsy again after 2 years, measuring the bone turnover markers, the DEXA scan, and the new biopsy to see what has happened.
Okay, Ditte, I just want to stop here and ask the panelists. I mean, is this really like a necessity to redo a bone biopsy, or would you? I mean, you are happy. There's no new fractures. Patient is doing rather well. I mean, the DEXA results, probably you can show them, Ditte.
Yeah, sure.
So you do a DEXA scan, which is, I mean, everyone can do DEXA scans, and you see these results. Would you be happy, and would you convert this patient to an anti-resorptive agent, or what would you do? Or would you say, okay, without, I need a bone biopsy, and then you have to explain me why you need a bone biopsy? Renate.
Well, first it's quite remarkable, the DEXA results, that what we see is that the lumbar spine did not change at all. Whereas, and that's quite contradictory, you see some improvement in the hip, well, while we know that the teriparatide has most effect on the lumbar spine. So first we need to be sure that everything went well with the teriparatide, that he took it, had no adverse reactions making him stop with the therapy or anything like that.
Yeah. As far as I know, he took it. I make prescriptions during the 2 years regularly, so I expect him to take the medication.
And also in this case, if it's an unexpected DEXA value, I would look at the pictures and put them next to each other to compare what's the real change.
There was some difference because it was 2 different DEXA machines. He was measured on the Luna machine 2 years ago, and Hologic at this time point. I don't know if you find that it could explain any differences at all.
Yeah, and perhaps the occurrence of new vertebral fractures, because Pieter, you said it all went well with the patients, but I don't know actually on which data you base that it went well. He still has pain, and well, there may be something going on in the back further on.
Yeah, that's an important point. So he didn't have acute back pain, but I mean, this is saying a little. So potentially what you're advising is to do another X-ray, or the VFA, for example, could be of help in diagnosing new fractures, whatever. So is this something that has been performed, Ditte, or?
No, unfortunately, I do not have a new X-ray, and he was supposed to have this vertebral fracture assessment, which is possible in the DEXA machine, but he couldn't be placed in the machine to obtain this. So unfortunately, I do not have these this description available for further fractures in the vertebral spine.
Yeah. But again, we have this case sitting in front of you in your office, so you need to do something. So do you really need a bone biopsy again, or would you? I mean, like you planned in advance, Ditte, but you have the luck to have access to bone biopsy. So Susa and Renate, do you believe, okay, now I would just convert this patient to an anti-resorptive agent?
Yes, that's what I do.
Yeah, me too. Yeah, probably if I will do another X-ray or another image to discard another morphometric vertebral fracture. but with these results, maybe add TB, the trabecal burden score, may add some information. But if they had not another additional vertebral fracture, and I think that lumbar spine densitometry here, I don't know if it's too valuable or valuable. It's not 100% real, this value, and I don't know, it's very, very true. And but in the hip, it seems it's not. Is a little bit better, and if he has not fractured, I will maybe add an anti-resorptive treatment.
Yeah, something again which is, yeah, go ahead, Renate.
Well, I was just wondering, because somewhere you mentioned, Ditte, that the man also lost weight because he has chronic pain, of course, since his vertebral fracture, and that influences the DEXA measurements very much. So indeed, did he lose weight, and how much in the meanwhile?
I think he lost around 5 kilograms around this, and he also reduced his physical activity during these two years. Like he got, yeah, you may say older, of course, but he lost his like physical activity. I think also partly due to the back pain, also.
And he also starts using the oxycodone, which is also not favorable for his bone mineral density. So there are also several accompanying factors in the 2 years. Would you expect that he would go down in his bone mineral density in the 2 years? So perhaps he is still in the same value because of the teriparatide treatment.
Mm-hmm. I think we have to come to a conclusion again. As discussed, it's a very interesting case, Ditte, and unfortunately we cannot reach the end of your presentation, but I think this is like an extreme nice cliffhanger for one of the next or the forthcoming webinars where we can discuss the follow-up of this patient, because indeed you performed or you biopsied your patient again, and the results are very remarkable and certainly also worthwhile a further discussion. But as said, I do believe that the process, the way of thinking on this case is much more important than the final solution that we could offer. So I suggest that we keep this for one of the next coming webinars. I mean, this is like a podcast where we discuss an interesting case, and I hope you all enjoyed the discussion and how to deal with a case which is not uncommon, but at the same time is also very difficult. Again, the combination of osteoporosis and of a low bone turnover, how to deal with these patients. So I would like to thank the speaker, Ditte, Hansen, and also Thomas for giving a very nice discussion of the bone biopsy. I also thank the panelists for a really beautiful discussion. And again, looking at all the questions in the Q&A, there's many more that needed to be addressed, but we did lack time, and this is always a good sign that people are interested and there's need for this kind of discussions. Again, learn by practice. So this will be not the last webinar, there's more to come. And the next one is scheduled March 18 in 2025 and May 6. So please already mark your agenda. And those of you who are really interested to learn more about bone and how, for example, how to interpret DEXA results, PBS, high resolution PQCT, whatever, and also have insights on, for example, the impact of diabetes on bone, I would certainly cordially invite them to join the next Lloret winter meeting held in Leuven, Belgium, from 15th to the 17th of January. The abstract deadline is very close, so please submit your abstract. And also, if you want to have the registration at a reduced fee, it's time to go to the ERA website and search for the winter meeting and register for that meeting. We would love to welcome you in Leuven. And also, you can follow us on X at Lloret online. And with having said this, again, thank you all. Have a nice evening and hope to see you on one of the next occasions. Thank you.